Welcome, welcome. My name is Brittany Johnson. I am a licensed professional counselor and also a licensed substance abuse treatment provider. I am going to be walking us through ASAM today, wanting to just let you all know that everyone's cameras today are off and microphones are muted. We will have a chance throughout to have some questions. We're going to do some breakout sessions and things of that nature. And so we will be able to kind of integrate some of what we're learning into actual, understanding through scenarios. So let's get started. ASAM, standing for American Society of Addiction Medicine. I just want to put out a disclaimer that this training is an overview, is 2 hours, so it is not meant to be all encompassing of ASAM methods of use and implementation. As I go through the material, I will also speak about ways that you can take on additional trainings if you see fit that you want to go more in depth on learning all about using the ASAM model and methods and interventions for assessment, okay? Just some training objectives today. Wanting to ensure that by the end of this training, you feel well-versed in that you've received an overview of the ASAM model, that all ASAM levels of care have been reviewed, and that we've also explored the use of ASAM in treatment planning. All right, so the ASAM criteria is most widely used set of standards for placement in continued service for patients with addiction and co-occurring conditions. So the ASAM is formally known as the ASAM placement criteria, and it can be used for both adults and adolescents, okay? It is the result of a collaboration that began back in the 80s to really define a national set of criteria for providing outcome-oriented and results-based care in the treatment of addiction. So we look at levels of care recommendation, treatment plans, all of these things being developed based on the patient's assessment that considers their biomedical, social, psychological needs, okay? The ASAM criteria is a multi-dimensional approach, and it helps clinicians and care managers make a more objective decision about patient care. So firstly, the ASAM improves patient outcomes by providing a common language for assessment and treatment across addiction, mental health, and physical health services. It accounts for multiple areas of life, and it considers many different facets or dimensions, and it looks at those risks, needs, strengths, and resources, okay? So really objective decision-making to improve client outcomes. It's a comprehensive approach. But before we can really dive into the understanding of ASAM, we need to truly maybe have a better understanding of addiction, okay? So understanding addiction, there are several types of substance use disorders, opioid use disorder, alcohol withdrawal management. We need to be aware of how all of these substances impact the individual. We also need to be aware of the neurobiology of addiction. So neurobiology is essentially the study of cells in the nervous system and how they interact with each other. Here's a visual. So when we talk about the neurobiological theory of addiction, it sounds kind of complicated, but since we know that neurobiology is the study of those cells and how they interact with each other, I give you the visual of you going to the oven, you opening grabbing the pan, forgetting to put on an oven mitt, and instantly like flinching, pulling your hand away. And all of this actually happens before you ever even feel any pain. So neurobiology explores how the brain helps you to make conscious and unconscious decisions. So for years, it was commonly believed that addiction was a moral failing. We know now that this myth has now been debunked thanks to the research into the neurology of the brain. So studies now show how the development of addiction is directly related to changes in brain function and structure. So It's widely accepted that the cycle of addiction falls into 3 stages, each one having a different effect on the brain. And when repeatedly exposed to substances over a long period, the brain alters its response to reward in executive functioning, which creates irreversible changes. So if we look at this kind of blue section at the top, the binge intoxication little area, we know that at this point, a person is enjoying drinking alcohol or taking drugs, right? The brain is engaging in its pleasure receptors and dopamine levels increase. So this results in a feeling of euphoria, relaxation, and intoxication. It feels good, and it's probably numbing to some of the things that you may be dealing with, right? Then we look to the right-hand quadrant with the red. Then we go to withdrawal. So then when a person stops using the substance, the brain's reward pathways are impaired and the stress response kicks in. So the brain may respond in the form of convulsions, tremors, brain zaps, anxiety, paranoia, and hallucinations. And we know that also there's studies that show that the dopamine levels, we all have dopamine levels, and we know that during this binge intoxication RAM that those are heightened, but it actually shows that during this withdrawal period, those dopamine levels fall lower than they ever would if there had never been substance use. Hence why individuals who are maybe not using will experience like depressive symptoms and anxiety and sadness, because there truly is a decrease in the chemical makeup of the brain since starting to use and going through that cycle from binge intoxication to the withdrawal area. So finally, in the green, as we circle on around, there's the preoccupation anticipation phase. So as the person starts to become preoccupied by the idea of drinking and taking drugs, the brain's executive functions become compromised. So this causes the brain to have difficulty regulating actions, emotions, and impulses. It's also noted that this prefrontal cortex area of the brain actually begins to break down during this phase. So there actually is the chemical makeup of the brain is actually being diminished. So when you ask maybe what part of the brain actually causes addiction, there's not one particular part that's responsible, but there are several regions and neurotransmitters that all work together. And when drugs or alcohol are abused, these intricate parts kind of get thrown out of balance, okay? Different parts of the brain are disrupted at each stage of this addiction process and play a role in the onset of substance abuse. So at the top of this list is the mesolimbic dopamine system, or the reward pathway of the brain. This key region is the part of the brain that gives us pleasure. So following years of substance abuse, the brain becomes desensitized to substances such as opioids, cocaine, and alcohol, resulting in increased dopamine levels, which can reinforce compulsive behavior. So again, just a good visual showing how each of these phases kind of flow into each other in the damage that it caused the individual due to the damage that it is causing in the understanding addiction. Also, we need to be mindful of the environmental and the societal impacts that addiction has on the individual. So being aware of someone's trauma exposure, their social isolation, whether it's peer pressure, maybe there's a family history of drug use that makes them more susceptible. Maybe there's drug availability, low or high SES, depending on what's going on. Norms, military service, media, advertising. So there are lots of different environmental and societal impacts that roll into addiction. So just keeping in mind as we start to move forward and talk about the assessment tool of the ASAM, noting that all of these things play an important role in how we're acknowledging and understanding what our client or our patient is kind of telling us or how they're presenting when we are assessing them. We have a better gauge on addiction. We're going to slide on past and look at the addiction process, okay? The assessment process, I'm sorry. So, understanding the assessment process. So, we have talked about how ASAM originated. We've talked about what addiction is and how it presents, how it impacts the brain. So now we have a better understanding of how we enter into the assessment process. So let's look at the ASAM as a holistic framework for addiction, consisting of 6 dimensions. So the 6 dimensions of ASAM serve as a comprehensive framework for assessing individuals with SUD and guiding personalized treatment planning. It's going to evaluate intoxication and withdrawal potential to determine the need for medical intervention. It's going to consider biomedical conditions that may also complicate recovery, and it's going to address emotional and/or cognitive issues that could impact treatment's effectiveness. Additionally, it's going to assess the individual's readiness to change. This is going to be very crucial for engagement in the recovery process. It's also going to examine the recovery environment to identify a person's social supports and potential triggers. So together, the dimensions kind of facilitate a holistic understanding of the individual's needs, and it enhances the likelihood of successful outcomes. The assessment process with ASAM is wanting to truly look at each individual as a whole person, separate from other individuals. So it's really forcing us as the assessors to take a kind of take off our rose-colored glasses and really understand each individual's what they're going through and what maybe is impacting their motivation and things of that nature. So the initial assessment will gather biopsychosocial information. It's going to assess risk and protective factors and evaluate mental health concerns while identifying co-occurring disorder. It's going to be asking clarifying questions, and using observation is going to be critical. So in starting the assessment, you may start by saying, hey, before we get started, can you tell me about why you've come to meet with me today? You run a probe. How can I be of help? What are you seeking treatment for? You want the assessment to be conversational. Example is also going to be identifying with what the client is telling you, but also being aware of what you're observing through nonverbal. This is just a look at the ASAM criteria dimensions and changes to that have occurred in the 4th edition that has recently rolled out. So recognizing that the 3rd edition changes are that readiness for change is no longer being looked at as a dimension in the 4th edition. Readiness for change is now being looked at across all dimensions as you're identifying the severity rating. It's also going to talk through the fact that what was dimensions 5 and 6 are now dimensions 4 and 5 in the 4th edition. They carry a bit of a different name in the 4th edition, but it is still very similar to what it previously was. So those are the big changes of readiness for change really being looked at across all dimensions. And then we have this new added 6th dimension, which is person-centered considerations. So we're going to walk through each dimension. The first being acute intoxication and/or withdrawal potential. This dimension focuses on assessing whether an individual is currently experiencing intoxication from substances or if they're at risk for withdrawal symptoms. So it's going to evaluate the severity of substance use, identifying the need for any type of medical intervention or detoxification. So key factors are going to include the types of substances being used, the duration, and the frequency of use. and the individual's history of withdrawal experiences. So, recognizing this potential is going to help ensure safety and appropriate care during treatment process. Then we have to look with each of the dimensions, we're going to have to assign a severity score. That's going to just help us to explore where along a continuum does the client or patient lie as it relates to each dimension. So the severity rating is always going to be on a scale from 0 to 4, 0 being none or the lowest, with 4 being the most severe. For this intoxication, withdrawal, and addiction dimension, the severity is going to be assessed with 0 indicating no withdrawal potential, meaning that the client is stable and there's no risk of withdrawal symptoms. A score of 1 reflecting mild withdrawal potential, characterized by occasional mild symptoms that don't signify impaired functioning. A score of 2 suggesting moderate withdrawal potential, where the client may experience symptoms that require monitoring but are not immediately dangerous. A score of 3 indicating severe withdrawal potential. Often this is going to be based on a history of severe withdrawal symptoms that could pose risk. And finally, a score of 4 denoting a critical situation where severe withdrawal is present and there may be immediate medical attention that is needed. So this is going to look like perhaps seizures or delirium, okay? It should be noted that in this section, you may be meeting with a client and asking the questions, having the conversation, when is the last time you had anything had any alcohol, or when's the last time you had any substances that you've used, and the client may be telling you one thing, but you may be observing something very different. So you want to be mindful of not only what you're hearing, but what you're observing. Client may tell me, oh, I last drank 2 weeks ago, but I may be actively smelling alcohol on their breath during my assessment. Or the client may indicate that, they have never had any type of withdrawal symptoms. And I may be able to note during the interview that they're shaking or they're slurring their words. So these are things to just be aware of, not just listening to what you're hearing, but being aware of maybe those nonverbals that you're observing within the client's behavior. Moving to dimension 2, we have biomedical conditions and complications. So this dimension examines any medical issues or physical health conditions that could affect an individual's treatment for substance use disorders. So this is going to include chronic illnesses like diabetes or heart disease, high blood pressure, any infectious or diseases, hepatitis, or any complications arising from substance use. So maybe a liver disease or respiratory issues. Again, severity scale 0 to 4, 0 indicating there's no medical conditions, while a score of 1 reflects conditions that are manageable without intervention. A score of 2 is going to suggest moderate conditions that require regular monitoring or treatment. A score of 3 is going to indicate severe conditions that significantly impact treatment and may necessitate coordination with medical care providers. And finally, a score of 4 denotes critical medical conditions that require urgent care to address immediate risk. An example to this may be a client presents and identifies with having diabetes and needing to take insulin, right? Where that would fall on that continuum of severity is really going to be indicative of the management of that diagnosis. So perhaps the client does have diabetes and takes insulin, but it's very well maintained. It's been well maintained for years. And so the severity level is going to be lower than perhaps someone with the same diagnosis whose levels seem to be out of whack, has a hard time, navigating and maintaining their sugar levels. This is all something you'll want to be mindful of when we're thinking of the severity level that we're giving in a particular dimension. Next, we have dimension 3, psychiatric and cognitive conditions. This is going to look at the mental health and emotional well-being of individuals with substance use. It assesses any co-occurring mental health conditions such as depression, anxiety, PTSD, and it's going to look at cognitive impairments that might hinder their recovery process. Severity level, again, 0 to 4, 0, no significant issues, 4 reflecting critical issues requiring immediate intervention. So such as suicidal ideation, severe psychosis, and scores of 1, 2, and 3 being mild. Now we have 4 and 5. 4 is one of the new transitioned into the fourth edition. Like I said, very similar still to what it was in the third edition, just kind of given an updated name of substance use related risk. So this dimension assesses the likelihood that an individual will engage in risky substance use related behaviors. It considers the person's recent and historical patterns of use and the potential for dangerous consequences, such as like overdose, DUIs, risky sexual behavior, even criminal behavior. Okay. 0 to 4 on that severity scale, with 0 being none, 4 being that there has been a history of some of these risky behaviors occurring, some of these risks that are related to substance use. And it has to be, you want to be mindful in this section that the risk is directly being impacted by the substance use. So a person who perhaps as a teen maybe had some legal troubles, but it wasn't associated with their substance use, may not need to be scored at a 3 or 4 in this area because it wasn't a direct relation to their substance use. Then we have dimension 5, recovery environment interactions. This dimension is going to explore an individual's ability to function along with their safety and support in their current environment. So if a person is not currently functioning effectively, they may benefit from developing their social skills or their independent living skills. So a person's needs in this dimension could include housing, financial, vocational, educational, and some transportation services, just to name a few. So the clinician can examine whether others external to the client also pose a threat to their recovery and treatment. So we're going to want to know in this dimension, who is it that you rely on, or who in your family can you depend on? Who in your family has not been supportive of your, the motivation you have for recovery? What does that look like? What is hindering, you in your life currently to feel that you can function well in your environment? Do you not have adequate housing? Do you feel as though your education isn't where it should be for you to gain employment? So really kind of having the conversation and walking through some of these things with the client is going to be beneficial for this area in identifying kind of what the severity rating is here. So this severity rating within dimension 5 is also going to assess the individual's ability to manage their cravings and identify triggers, and utilize skills that will ultimately avoid any type of relapse. So higher rating indicating a greater risk of continued problems or relapse. Next, we have person-centered considerations. In this dimension, we consider a person's obstacles to care, and their treatment preferences and their need to enhance their motivation. So the goal is for the clinician and the patient to practice a shared decision-making to determine the appropriate level of care while respecting the person's autonomy, their culture, and any trauma that they've experienced. The severity rating assesses the level of support or the potential obstacles related to support within a person's social surroundings. So a higher rating indicates a more challenging environment where recovery may require additional support. And so those are the 6 dimensions. And lastly, though it's no longer identified as a dimension, like I said, the 4th dimension enforces that readiness to change, that it be looked at across all dimensions. So really exploring as the individual is sharing information with you, as you're observing things through assessment, what makes this person ready for change? Are they not ready for change? You really want to consistently be thinking through that as you're assessing these 6 dimensions. So this is just another look at those 6 dimensions and the key concepts that are covered with each. So these are kind of some sub-dimensions. So of course, with dimension 1, intoxication, withdrawal, and addiction. We're going to look at associated risk, withdrawal and those risks, addiction medication needs. Within dimension 2, medical conditions, their physical health. Also, here you're going to want to think about any pregnancy-related concerns or sleep problems. Psychiatric and cognitive conditions, dimension 3. Any type of persistent disability, you really want to focus on cognitive functioning. Dimension 4, we're going to do substance use related risk and the likelihood of risky substance use. Then we have recovery environment interactions. We're going to look at safety in their current environment and support in their current environment. And last, dimension 6, person-centered considerations. We're going to really look at barriers to care, patient preferences when we're thinking through just what may be best for this client. So we've kind of been able now to understand the 6 dimensions. The next phase, once you're going through assessment and you're evaluating each of these dimensions, and later on, I have a handout and things that you all will get upon the end of the training that makes a lot of this assessment pretty easy and kind of walks you through different questions and ways to really engage with the client regarding these areas. But getting the most information you can in this area is helpful because it's what you're using to now review what level of care is going to be best with them. So levels of care refer to the varying intensities of treatment services provided to individuals with SUD, and they're going to be tailored to their specific needs and circumstances. They're going to range from less intensive outpatient services to more intensive residential care, ensuring that individuals receive kind of that appropriate level and support based on the severity of their addiction or their recovery goals. So this image just shows kind of that 0.5 to 4. This isn't all inclusive on this photo of all of the levels. It's just kind of given the broad specific levels, but not really any sub levels that we'll kind of talk through. So first, we're going to start with ASAM level 0.5, which is going to be early intervention. It's going to focus on intervention for individuals who may be at risk of developing a substance use disorder. And the goal is to prevent like that onset or more severe issues through education, counseling, and some support. So this level is going to target individuals who show early signs of use or are at risk due to maybe their personal, social environment. The services are going to be brief interventions, maybe including like some motivational interviewing, some screening, some assessment, maybe some education about substance use risk. And it's also going to be noted here that should you need to at any point at this level, you're able to make a referral to a higher level of care, okay? So what's nice about the early intervention services is that they can be provided in community settings. So your outpatient clinic, your school, and also it addresses potential substance use before it escalates. So it's really going to help reduce any. These services are going to be very accessible, making it more likely that individuals might seek help. So it's going to be cost effective. It's going to be a lot less effective. It's going to kind of be that prevention piece when we're thinking of levels of care. So really trying to impact the individual before there is a substance use disorder to reduce any type of ongoing necessary treatment in the future. So a lot of times this may be identified because there is going to be a reduction on the financial burden on the individual and also the healthcare system within this. The goal here is going to be that by addressing the risk, we can also motivate the client to make some healthier choices and that we can provide like some resources and some wraparound support. Okay. Then we have level 1, which is going to be what we all kind of look at as like your outpatient services. So it's going to be targeted for individuals with a substance use disorder, but who require less intensive support. So it's going to include like regular therapy sessions. It might include some group therapy, but it's nice because it's going to allow an individual to maintain their daily routine. So they're still able to go to work and go to school, but they're able to engage in the services. So this too is going to be able to be held at an outpatient clinic, a community mental health center, private pay practices. But what's nice too about level 1 is that it can be done via telehealth platforms for increased kind of accessibility. Again, kind of like level 0.5, offering that flexibility, which kind of encourages individuals to engage because they can still fulfill all of their professional obligations and personal obligations as well. It is important to note that there are additional like sub levels to level 1 that are still within that outpatient kind of grouping, but are just a bit more specified as it relates to maybe what may be most important in that level or what you might look at when determining between those sub levels within level 1. When I provide the handout for us to review during the scenarios, you'll be able to kind of see what I'm speaking about as far as the sub levels, okay? So then we have ASAM level 2 is going to be intensive outpatient services. It's going to focus on the intensity of treatment. So intensive outpatient is going to be several different interventions happening throughout the week. And it is designed for those who require more than just a basic outpatient care, but they don't necessarily need 24-hour supervision. Okay. So it's going to, like I said, involve kind of structured treatment sessions that are going to address their specific needs. So education, counseling, groups, all of those things can still be involved. So the goal is that they're going to achieve some stability, but it's going to foster a deeper kind of understanding of their addiction and their recovery process with a lot more oversight. So in this level 2, there also may be instances of, drug testing and a lot of these other factors that are ensuring that the client is engaging and maintaining their recovery. Next, we have ASAM level 3, residential inpatient services. ASAM level 3 encompasses residential and inpatient services that provide 24-hour care for individuals with substance use disorders and who require a structured and supportive environment. So this is going to be ideal for those who are experiencing severe addiction and significant withdrawal symptoms or any co-occurring mental health symptoms. So it's gonna involve like a comprehensive multidisciplinary approach with like the medical oversight as well. So they're gonna be able to obtain group therapy, individual therapy, but also that medical monitoring and also perhaps psychiatric medication involvement that wouldn't perhaps be available at a level 2. So a level 3 is really providing that 24-hour oversight of the individual receiving services. So it also is going to allow the individual to fully focus entirely on their recovery. So it's really taking away all the external individuals or things that maybe have impacted the client's ability to continue their recovery and really break down what it is they're going to need to really be able to move forward on their recovery. And then within level 3, we also have those sub levels. So the next level after 3 is 3.1. We're going to look at that as being clinically managed low intensity residential services that provide a structured, supportive environment also for individuals transitioning into treatment for substance use. So again, it's going to combine that clinical oversight, the peer support, the counseling, the psychoeducation, all within that 24/7 access for the patient's safety. So it's really going to be ideal for those who are experiencing the moderate substance use and often with those co-occurring mental health conditions as well. And ideally, candidates in this level have completed more intensive treatment, but they need maybe continued support. So maybe they've stepped down from level 3.7 or 4, and they're just continuing to step down, but they're still in need of that 24/7 support. There's been progress, there's been some improvement, some growth, some strengths, but there's still that need for assistance. And now we have level 3.5. It's going to be clinically managed medium intensity. It's going to offer a higher degree of clinical oversight and support. And also medical, psychological needs are going to be able to be met there as well. And so with that, it can work with someone who does have a co-occurring diagnosis. And the therapeutic approach is going to combine evidence-based practices with support from peers and staff, patients, going to promote emotional regulation, ensuring that they're going to receive the necessary support for their unique challenges. 3.7. So all of level 3 is kind of under that same gradient of 24/7 care. It's just going to be based on the intensity of the residential services. So again, 3.7, clinically the same, providing all of the same stabilization services. But in this particular level of care, a patient is going to present perhaps with acute withdrawal symptoms, so severe co-occurring disorders. So we're still looking at the continuum and the variant of how severe the co-occurring disorders are within level 3 based on the 3.1, 3.5, 3.7. So the focus of 3.7 is to create a safe environment where the individual can receive their intensive medical and their therapeutic support, and also still work toward building that foundation for recovery. And finally, we have ASAM level 4. It's going to be medically managed intensive inpatient services. So this is for individuals with severe substance use disorders who require 24-hour medical and nursing care. So patients in this level are typically experiencing like significant physical and psychological complications from substance use, and it's going to necessitate like that intensive monitoring and treatment. So that might be detox, medication management, it's going to be needed, and that comprehensive psychiatric support. So a lot of times, level 4 detox, when we're thinking of someone who is actively using and wanting to go directly into detox treatment, it's going to be level 4, okay? So here is an ASAM crosswalk. Because the 4th edition is kind of new, a lot of these items are very difficult to get your hands on in like a PDF file. But in the same way that the 3rd edition did, the 4th edition kind of walks us through a crosswalk of being able to look at the dimension in the severity rating that you're giving the dimension and kind of cross-reference that with the best level of care. So that's not to say that it's always right on target that, oh, I came up with this rating and this one, and this is the level of care. It's meant to really be a continuous conversation and really rationalizing what's going to be best for your client. So a way that you typically can kind of get in the ballpark of where you need to be as far as level of care is to take the severity levels 0 through 4 that you've maybe identified for each dimension and divide them by the number of dimensions to get a score. I say that you can utilize that, but I wouldn't rely only on that to identify the level of care, because we're wanting to be specific about the individual that we're serving so that we provide the best care for that individual. So what may be 4 for one person with the same scores and the other person has 4, automatically looking at level 4, we may say, but based on these other aspects that I've observed, or based on their readiness for change, I might look at 3.7 because they have shown us a readiness for change. Or I may say there's no readiness for change. So yeah, a level 4 is going to be best. Like, you really just need to be mindful of who you're assessing, looking at them as the individual and not assessing them as like a group of symptoms, but really looking at the individual when thinking about this crosswalk. So I say that to say use it as an aid, but not to be all encompassing of it only being the right way to assess what level of care is best. Work it out on our own. So here are some of the scenarios that I want you to work through. You all don't have the crosswalk, unfortunately, but I'm gonna ask that you utilize any of your information, and then I'm gonna kind of walk you through the crosswalk and kind of help you understand why the level is what it is, but also knowing that potentially it could be something different depending on if we really had a full snapshot of this individual. So it's not to say that this is the one and only level of care that would work for this person, but it is just to give us a quick kind of overview based on what we've already learned about the dimensions and the levels of care, what may work for this individual. So so the first scenario is a 25-year-old college student has started using alcohol more frequently to cope with academic stress. After discussing their concerns with a campus counselor, it's recommended they attend a brief intervention program that includes educational sessions about substance use and its impact. And it says, what level of care would this be? And of course, this is gonna be early intervention. She started using alcohol more frequently, but currently there isn't the substance use disorder. So we're really going to want to target the ability to provide psychoeducation, to assess some of those risks. Perfect. 0.5 may also be it. Yep. 0.5. Great work, y'all. So we're really going to just want to address maybe what's going on with her. And at any point, if we see that her alcohol level continues, we'd be able to then talk about, a higher level of care. Thank you, Mary, for sharing that crosswalk. Looks like you were able to find it. I appreciate that. All right, scenario 2. A 22-year-old woman with a severe opioid use disorder is admitted to a facility after experiencing an overdose. She receives 24/7 medical supervision and participates in various therapies, including cognitive behavioral therapy, CBT, and family therapy, focusing on her recovery and coping strategies. Level of care. Okay, we have some 4s. We have 3 to 4, 3.7. I think it could be, I would say more so in the 3s, but I can definitely see those of you who picked 4. I'm guessing that when you've picked 4, you're looking at the fact that she's receiving 24/7 medical supervision because she just experienced an overdose. And we don't know if she's still initially going through those withdrawals of the overdose, which would definitely be a 4, level 4 of care. But because she's experiencing, also participating in the various therapies, including cognitive behavioral therapy and family therapy, and focusing on those coping strategies, it could also be within that 3 family as well, but you would definitely probably want to look at a lot more specific details surrounding the dimensions and identifying kind of what her level, her readiness for change was. And that may help you to really navigate between kind of that 3 and 4 spot. Scenario 3. A 40-year-old man with a history of alcohol use disorder completes a detox program, but requires additional intervention at this level. Intervention at this level meets 3 evenings per week where he attends group therapy sessions and individual counseling, and the program helps him address underlying issues and develop a support network. What level of care is this? Yep. All of you are right on track. That intensive outpatient. Yep. Scenario 4. A 30-year-old professional has been drinking heavily on weekends and is beginning to notice negative effects on their job performance. It's recommended that they attend a program that offers weekly individual therapy and group sessions focusing on relapse prevention, coping skills, and healthy lifestyle choices, which being able to maintain his job. What level of care is this? I'm going to agree with level 1 outpatient. Again, though, this is not telling of the entire story with this individual. You always want to address what you're seeing in those dimensions, what you're hearing as far as those dimensions, and make the best level of care choice with that. And then those who are looking at the crosswalk, kind of it gives you those little instances of what each level may look like and what the withdrawal potential may be. And so using that to your benefit as well. Scenario 5, 28-year-old individual in recovery from methamphetamine use requires a structured environment but has stable medical conditions. It's recommended that they participate in group therapy sessions and engage in life skills training, helping them transition to outpatient care. What level is this? This one has some mixed reviews. I see some 2.5, some 3s. 3.1 is what I'm gonna agree with here. I think the last person I see who said 3.1 is gonna be Melanie, Yana. All of you are right on track with that 3.1 or within that 3 framework, especially when it's talking about a structured environment, but she has some stable medical conditions, wanting to transition to outpatient care. In that structured environment is kind of the key as well. Scenario 6, a 45-year-old woman with a dual diagnosis of alcohol use disorder and depression enters a program after a crisis that involved suicidal ideation. She receives intensive therapy and medical management, including psychiatric support to address both her substance use and mental health challenges. What level is this? We're across the board here. 3.7. I'm agreeing with 3.7. Yes. It's remember that 3.7 is characterized by a high degree of clinical intervention. And they're going to be presenting with acute withdrawal symptoms, severe co-occurring disorders. And especially with that psychosocial instability, we're looking at her talking about having the suicidal ideation, recent crisis. So 3.7 is going to be a good level of care. Scenario 7, 35-year-old man recently relapsed after completing outpatient treatment. He requires an intervention that provides a higher level of care with more frequent individual therapy and medical oversight. The focus is on stabilizing his mental health and developing a robust relapse prevention plan. What level of care is this? See lots of 3s, 3.5. Yes, yes. Definitely within the 3s. I think we'd have to assess more to understand where within those sub-levels that would lie. I would say 3.5, but I can't negate those who have indicated 3 or 3.1. We'd really just have to look at the individual's readiness for change and really assess all other areas of the mental health component that the individual is dealing with. What are those symptoms and things of that nature? So scenario 8, a 50-year-old man arrives at a hospital after being found unconscious due to a combination of alcohol and benzodiazepine overdose. He is admitted to a program where he receives continuous medical monitoring and stabilization, along with psychiatric evaluation and treatment to manage withdrawal symptoms. What level of care is this? Way to end it out. Perfect. Level 4. And we know that based on understanding the medical monitoring piece, continuous, the psychiatric evaluation, the treatment, and then the management of withdrawal symptoms. So all of you are right on target with 4. Perfect. So we've been able to navigate the dimensions, the severity ratings, looking at that in connection to the levels of care. Now let's talk through some standardized assessment tools and then treatment planning. So ASAM has made it really easy to assist you with assessing clients and identifying level of care. They've tried to take a lot of that like guesswork out of what the levels are. So some of these I have as links when we send out the information after everyone fills out the link for saying that they attended the training today that you'll get. So one of them that you're going to get is the ASAM Continuum. This is going to be an electronic assessment tool. It uses a computerized system to help clinicians and counselors assess patients, clients. So it does collect information across the 6 dimensions. And what's nice about it is it is able to then generate like a report based on kind of the responses to any of that questioning. Also, some standardized tools that ASAM has is this code triage. Now, this is going to be computer guided and it's going to require like an additional payment to have this system. But ASAM has created this computer guided tool that generates like the initial level of placement as well, kind of the same as the continuum. The difference just being that you don't have the narrative that it provides at the end. It kind of just generates a score for you. Then there's also what's called an ASAM criteria navigator software that helps with kind of like utilization review and management workflows as it relates to ASAM. And then ASAM also provides like an interview guide that you'll get as well. It's like a nationally recognized tool, and it includes assessment questions and forms that kind of cover the dimensions. Also, it should be noted, like I said at the beginning, that this training is not all inclusive. There are several multi-day trainings that are devoted strictly to ASAM that they provide. So all of those trainings and education tools can be found on ASAM's website, and it really can help clinicians kind of hone in on their ASAM assessment skills if they're interested. So now we move into treatment planning. So we've done the hard work, right? We've met with our client. We've established, okay, based on what they're experiencing, based on their past, based on their motivation, their readiness for change, let's develop a treatment plan, okay? So the core principle of the ASAM criteria is going to be that treatment plans are individualized and they're based on the client's needs and preferences. So they're informed by the multidimensional assessments that were discussed previously. Everything that you have gained as information from this client is going to impact what this treatment plan consists of. When creating the client's treatment plan, you're going to want to ensure that you're capturing the following: the concerns that were observed within each dimension, the client's strengths, and the client's preferences and barriers to care. That's why it's so important to really go all in when you're getting the assessment. Try your best to engage the client, not just with what they're telling you, but what you're observing, what you know from maybe their history, really utilizing all of your assessment skills to gauge and understand the client as best as possible. You're also going to want to remember that collaboration is key when it comes to developing this plan. It should be collaborative, and it should be a process where the patient and their care team are working together. The client should be engaged in shared decision making. That kind of starts with that initial question of like, what do you want from treatment and why now? What is your why? Clinicians should work with the client to explore what has worked previously and what hasn't. You want to think through some of the techniques you might utilize, like motivational interviewing approaches, where you can use those throughout the planning process to really assess the client's readiness for change, but also their confidence in moving forward in the recovery process. We always want to make sure that our treatment planning is being conducted in a trauma-sensitive and culturally humble manner. And that the goals do reflect the factors that motivate the client to participate in treatment. And we're using their own words. We know that from just any treatment planning that we're doing. Personal goals should be reflected and the patient's strengths should be incorporated. Treatment planning should also consider the need for family-focused interventions such as family therapy. And then, of course, when we're talking about treatment planning, we want to ensure that we're discussing how we're measuring success. So, some things that you want to kind of keep in the forefront when you're measuring success are the following. Like, is the client achieving and are making progress toward their identified goals? Are you noticing changes in any of the 6 dimensions? Is there a readiness for change? Is there emotional and cognitive awareness? And how has the treatment plan changed to reflect this progress? So if my client initial treatment plan, they're in level 3.1 as their level of care, my treatment plan should not look the same once my client perhaps is now in level 1. So we have to be aware of ensuring that those treatment plans are changing to reflect any progress. And although we can't deny that there may be kind of challenges or barriers to treatment, we also want to include like what they look like and how are we capturing also these instances in our treatment planning. You know, if my client was doing well in IOP and perhaps my client experienced a death in the family that was very close to him, and perhaps my client then had a relapse of some sort, how do I show this in my treatment planning? How might I capture instances like that to show that something has occurred that has impacted my client, and it has led to a relapse or a increase in the level of care that may now be needed? We also want to discuss how we might adjust the best level of care to meet the client's needs. So maybe it's the opposite. Maybe my client is level 3, but my client is doing really well. How do we adjust and make sure we're meeting the mark when it's time for maybe my client to take a step down in the level of care? How are we maybe beefing up that treatment plan so it's more supportive around that individual during that time that may be a bit more challenging? Always remembering that the level of care identified in the beginning of treatment may not stay the same. And the process may not be linear, as I kind of discussed a second ago. Maybe they're transitioning into a lower level of care, or maybe something's happened and we now need a higher level of care, which is why it is so important to consistently be reviewing those treatment plans and making the necessary recommendations. So some key concepts, we're a little bit early since we didn't break into those groups. Some key concepts we just want to remember is how all of it kind of flows together, right? We have the 6 dimensions of ASAM, which is that update from the 3rd edition to the 4th edition, those 6 dimensions and how they align with the 5 levels of care, and cross-referencing the 4 and cross-referencing those across the different dimensions and identifying the severity rating. All of that is important when we're thinking of ASAM and identifying a level of care. Also thinking through the inclusive treatment planning and ensuring that we're always picking the safest level of care based on what our clients are presenting with and not looking at our clients as a general individual who is using a certain substance, but really specifying each person as to what they need and why, understanding that they each come with different backgrounds, trauma experiences, and using all of that to make the best treatment plan that we can to ensure success as they kind of navigate along the levels of care. I don't know how Michelle would prefer to do it, but if this time, I don't know if anyone has any direct questions.